Good morning, everyone. Welcome to this edition of Data Breakfast. This morning, we all woke up to the very good news that South Africa eventually won the first gold medal at the Olympic Games. And I hope that Dr. Suliman will maybe share with us also maybe some positive news, or at least some hopeful news. Yeah. So the speaker this morning is Dr. Ridhwaan Suliman. He's a senior researcher at the CSIR, and he's working, and I have to read it because it's difficult to memorize, in the operational intelligence impact area in the next generation enterprises and institution cluster of the CSIR. Yeah, Dr. Suliman started his academic career as a mechanical engineer, but he got his PhD in Cambridge in applied mathematics. But I think he's been working most of the time modeling and designing physical systems within the computational mechanics domain. Yeah, and more recently, he became one of the authoritative sources of of information around the COVID statistic in South Africa. And I don't know, probably many of you probably follow him on Twitter and have seen him many times in the various news channels informing us about the status of the pandemic and of the vaccinations in the country. So Dr. Suliman, thank you very much again for being with us this morning. We are very, very keen to listen to your presentation. And if you would like to start sharing your screen, you're welcome to start. And while you do that, I will remind the participants to please make use of the Q&A facility at the bottom of the Zoom screen, so that Kimara Naikar and Dr. Sinaisky kindly agreed to moderate the question and answer session after the presentation. So Dr. Suliman, please, you're most than welcome to start with your presentation. Your screen, your slides are beautifully represented in Zoom. So thank you very much.
Thank you so much. Good morning, and thank you again for having me. It really is an honor to present on this platform. Good morning to everyone who is attending this. Thank you for waking up bright and early. So I think there's a lot that's that COVID-19 has changed in the way that we're doing things, and certainly there's a lot of data that has been shared, and that what is being shared on a daily basis, which is good for us that like data, and gives us a lot to do. Of course, it is a lot of pressure, and there's a lot that we have to keep up with as well. What I'll try and do today is to look at the different COVID-19 indicators, particularly the resurgence trackers that we monitor on a daily basis, and give an overview and update of these. But more so, I'd like to focus on what the limitations in the different indicators are, and what we need to be aware of, and why it's important that we look at various indicators, and in particular the trends in these indicators. So I'll try and focus my talk a bit on the limitations and the nuances in the data, and hopefully share a bit of different data visualization methods and approaches using what we have available. As a quick introduction, as I was kindly introduced by Prof, I am based at the Council for Scientific and Industrial Research, and over the last number of months been involved in the National Policy Data Observatory, which is incubated within the CSIR. The National Policy Data Observatory essentially is a data and decision support center that's a government-led initiative, and it provides from data collection to data storage down to different analysis, as well as trends in different measures, but also dashboards to track various types of data metrics and indicators. Over the last number of months, and my role has been heavily on the COVID-19 pandemic, and that's what I'll be speaking about. But the observatory goes beyond just the COVID. There's also various other data and measures, including district profiles and all sorts of indicators related to service delivery. There's socioeconomic indicators, sentimental analysis, looking at social media, as well as different other platforms. Also taking into account government surveys as well as other institutions, and a whole host of other measures. This slide just gives some sort of overview of what the Data Observatory does and its purpose based at the CSIR. To date, there's been a number of active contributions from the Data Observatory, including to various government organizations and ministerial departments. On a weekly basis, the COVID-19 data analytics are shared with the NextGen group, and that includes data analysis reports, all sorts of different trends, taking into account the global situation as well. And then of most importance is our own Resurgence Tracking and Monitoring. There's also regular reporting to the Interministerial Committee on vaccinations, and everything to do with vaccinations, from registrations to looking at the trends, as well as the rollout, to modeling and forecasting and advising on that. And then to various other government departments, including the GCIS, Department of Planning, Monitoring and Evaluation, as well as other groups. So that's just a quick overview of the Data Observatory within the CSIR. Moving then to the actual topic of today's talk is the COVID-19 data. As mentioned, there are a number of different indicators used to track resurgence and understand the situation in South Africa, as well as in the different regions, and then also how we're faring compared to other countries globally. Of course, this is a global pandemic, and it's important to also learn lessons from how other countries are managing the pandemic. On a daily basis, there is a lot of data that is being shared. Of course, for those of us that like data, there can always be more data, and certainly if there is more data available, we can always do more analysis and better our understanding of the situation. However, there is already quite a lot shared on a daily basis. The primary indicators include the number of confirmed cases, the testing and test positivity rates, the tracking of the hospital admissions, as well as people currently occupying beds in hospitals, looking at, unfortunately, the true burden or impact of the pandemic in terms of people succumbing to the virus. And those are shared on a daily basis, both at national as well as down to provincial and even down to district level. So there's a lot to analyze and digest there alone. We also, of course, track mobility patterns. We know the virus moves as people move. So what can we learn from mobility and movement patterns, and how can it be analyzed, and does it give insight to what could happen as a precursor to infection rates? And I'll touch on that. However, I don't want to just give an update and overview of the indicators. As mentioned, I want to try and also focus on the limitations. Of course, all of these data metrics and indicators have limitations. It's important to be aware of them. Maybe the first thing to point out, though, is everything that I'll be sharing is based on publicly reported data. So the first limitation, I guess, is that it is the data I share is as per reporting date. Of course, the tests that are reported aren't necessarily the same day, are not the same day that the test specimen was taken. So one can look at all of these different indicators by at least cases and testing by a test specimen date, which does, of course, make it, but overall, I think to also point out, while that is a limitation, it's not necessarily a bad thing, because overall the trends in the data still show the same result. Beyond that, there are other different limitations in the data, which I'll point out on but importantly, as mentioned, the trends in the data is quite important, and they do give a good indication of what's the situation. Also, the trends in the different indicators do correspond, because there remains a strong link between the different indicators. So getting straight into it, looking at the different indicators at a national level. First, if you look at the number of confirmed cases, this graph shows the 7-day or the average daily COVID-19 cases per week in South Africa over the past year. The height of the bars shows the average number of reported cases in the country for that week. Importantly, we know that cases are limited by the amount of testing that we do, which I'll get into in a minute. So the color of the bars represents the test positivity rate, or the proportion of positive tests or cases in relation to total tests conducted. So I think it's important, and I'll try and highlight the fact that cases do need to be looked at in conjunction with the testing rate, because our test positivity rates generally are high, and because of our testing strategy. Currently, nationally, we're reporting just over 11,500 new cases per day on average across the country. And that figure is down just over 11% currently week on week. Promisingly, we have on a national basis surpassed the peak of the third wave, and on a downward trend over the last couple of weeks, primarily driven by the populous province of Gauteng having surpassed its peak. The test positivity rate, as indicated by the color of the bar, still remains high, but that, as we'll look at in a minute, seems to also be on a downward trend, confirming that the decrease in infections is real. So in terms of confirmed cases, I think what you do need to be testing, because our testing strategy is one in which we don't do random or mass testing, but it's based on people presenting for testing either after being infected and showing symptoms, or coming in contact with a positive case. Therefore, the test positivity rate essentially is high, and so the more testing that we do does result in more cases. Essentially the number of cases that we do report on a daily basis is strongly linked to the number of tests that we do. Also, the testing does fluctuate, so we do need to bear in mind that there's fluctuations in testing, particularly over weekends and over public holidays, and recently over unrest periods. And so we make use of a 7-day rolling average to smooth out the data and account for these weekend effects. So all of the different indicators, when we refer to them, we refer to a 7-day rolling average rather than individual daily data points. The other factor I think to bear in mind is that there certainly are many more undetected and unreported cases. So what we are seeing, and the numbers that we do see, is certainly an underestimate of at least between 5 to 10 times, because many people may not test, or we simply aren't picking up all cases, or asymptomatic cases as well. So I think these are important considerations whenever we look at the number of confirmed cases. If we then move on to testing, I highlighted a little bit about testing, but of course, it really is crucial to understanding a lot about the COVID-19 pandemic and the spread of the virus. If the more we test, the better understanding we'll have of the spread and of our where we stand in terms of the situation of the pandemic. The testing, as mentioned, based on our testing strategy, it's not random mass testing, but one in which people present for testing after showing symptoms or coming in contact with a positive case. So counterintuitively, the number of tests that we do, or the testing curve, is more it follows the infection curve counterintuitively rather than the other way around. So when we see a surge in infections, we're generally also seeing a surge in the number of tests that we are conducting. As you can see from this graph, which shows the average number of tests conducted per day over each week over the past year. The last week, or at the moment, the 7-day average of tests is just over 46,000 tests per day across the country, and that's roughly about the same as what we were doing a week ago, and down from the peak of testing that we were at a couple of weeks ago. Sorry, I didn't mention, but the numbers above each of the bars shows the change week on week. So the decline that we're seeing in testing of late is likely a reflection of the decline in people presenting for testing and fewer infections nationally. Testing that we report on is a combination of both PCR testing, which remains the gold standard or most sensitive test to picking up virus particles. There's also the rapid diagnostic antigen-based test that we do in the country. We've been doing since October last year. And so both of those are factored into the testing numbers. When we look at testing, I think there are also then a number of limitations that we do need to bear in mind. I've spoken about the testing strategy and how the testing curve essentially follows the infection curve. And we see a surge in testing when we see a surge in infections. I've mentioned about the different types of tests that we're doing for detecting the SARS-CoV-2 virus. There may be some limitations in that we're not possibly reporting all of the antigen-based rapid diagnostic tests. I know a lot is being done to get all of those reported, but many of that is done outside of laboratory settings and may not necessarily feed into the reporting system. So I think that's something to just bear in mind when we look at the testing numbers. Of course, there's also testing capacity limitations in certain regions and areas. When testing is surging, the testing does get prioritized to only high-risk individuals, which may limit the amount of testing or how widespread and how many cases we actually do pick up if we do limit to only high-risk individuals. So that needs to be borne in mind as well. And not so much an issue now, but I guess a year ago, there were long turnaround times that we do needed to bear in mind, that sometimes tests results were coming back after a long period, which does affect then both the reporting and how to analyze the trends, but also then how practically to make use of the testing and the result. Maybe just a note in terms of testing, it certainly can be used as a proactive tool to combat the virus. As mentioned, it really is important to understand the spread and transmission of the virus, but it's most effective when when efficient tracking and tracing and isolation of positive cases can be done, and therefore it can be used most efficiently, but only when case numbers are low. And as a general guideline, when the number of, or the case incidence is below 15 new cases per 100,000 per day, that's still at a level that's manageable to do efficient tracking and tracing. Above that, it becomes quite difficult to actually keep up with the spread. Earlier on, I sort of just looked at a way to try and visually understand whether we are testing enough. And one way to do that is to look at the number of tests that we are reporting versus the number of positive tests or confirmed cases that we are reporting. Sorry, number of tests that we conduct versus number of cases that we report. And a nice way to do that is by plotting them against one another on a graph like this. What it shows is on a daily basis, the test versus those that are coming back positive, and that's tracked by the green line as shown here. Where you want to move to is you want this line to move to the top left of the graph. When you're sitting in the top left of the graph, that means you're testing a lot, and it also means that the number of cases is declining. So this kind of tells a story if you follow the line. If you're moving generally, sorry, this was done quite a while ago. So if you go back to a year ago, we were sort of moving towards the top right of the graph where testing was increasing as infections were rising, but the number of cases were also increasing. And so we weren't really moving towards the top left, but rather to the top right. And then you get these odd changes in the curve. This after just when we moved into a hard lockdown, the testing certainly decreased, dropped off considerably, picked up again. And then you see as cases started to surge and increase, the testing didn't necessarily keep up or pick up at the same rate. So you're sort of tending towards in the wrong direction. So maybe just a way to visualize whether we're testing enough and whether we're moving in the right direction was the aim of this type of of data plot. Although not being used so much nowadays, I think it still can be quite useful if you look at certain periods. We can also look at by shown in the dash by the dash lines is the number of tests that are being conducted per positive case, or what we now refer to as the test positivity rate. And you want to be conducting more tests per case. So you again want to be moving towards the top left, but not in the other direction. So maybe just a different way of visualizing this data. What we're more used to these days is the test positivity rate. It is a proportion of positive tests or confirmed cases as a percentage of total tests conducted. It really is a very important measure, and because of our testing strategy, becomes a crucial indicator to track in South Africa. As a guideline, the World Health Organization has recommended that countries keep the test positivity rate below 5%, and below that threshold will indicate that the pandemic is somewhat under control. And below 5% means that we're conducting 20 tests for every positive case found. Currently, the test positivity rate nationally is at an average of just under 25%, which is still high, meaning 1 in every 4 tests conducted is returning a positive result. But promisingly, it is starting to show a downward trend as well, confirming that the decrease that we're seeing in infections is real and not just an artifact of decreased testing. Because remember that the test positivity rate is positive test to total tests conducted. So while total tests have declined over the last couple of weeks, the rate of decline of infections has been far greater, and so the test positivity rate has been decreasing. So confirming that nationally we have surpassed the peak of the third wave. During this third wave peak, the test positivity peaked at just over 30%, not quite as high as during the second wave peak, where we reached about 34%, but still, be that as is made, it is still incredibly high. I want to just mention, though, that while the test positivity rate is really an important indicator and crucial to track, particularly in South Africa because of our testing strategy, the limitation is that it, of course, doesn't explicitly take into account the testing strategy itself, and when testing is prioritized to certain groups and individuals. So our test positivity rate generally does surge during surge in infections because, of course, more people are presenting for testing. So because of that testing strategy, we do see high test positivity rates. Of course, when testing is also prioritized and limited to certain high-risk individuals, it does mean that the test positivity rate will also increase. Of course, we can't only look at test positivity rate on its own to understand where we're at. It doesn't tell the absolute number of infections or the extent of the spread of transmission. We need to consider this indicator in combination with the number of reported cases. So these two indicators really are the number of confirmed cases and test positivity rate really are leading indicators, but they do need to be looked at in combination to understand what the situation or the spread of the virus is. I just wanted to show this graph, which overlays the number of confirmed cases during each wave in South Africa. We currently, of course, just past the peak of the third wave. Also, the color of these curves indicates the test positivity rate during that period. Of course, I do completely understand that the rate of testing has varied between the different waves. So it's difficult to read too much into it, but it still is nice to try and get a visual understanding of where we're at relative to the previous waves. Some things maybe that were quite interesting is that in South Africa, the different waves have been quite regular or cyclical, where each wave has lasted approximately 3 months, with 3 months in between the waves, which really is quite interesting and can tell us quite a bit about the spread in our country. We know that the peak of the third wave surpassed both the previous peaks, the 7-day average reaching just around 20,000 cases per day. The case incidence rate now is at just about 21 new cases per 100,000 population in the country per day, which is still high, but it's down to just under 60% of what we were at the peak of the wave. Primarily, the decline that we're seeing is due to the decline in Gauteng. So we know that the coastal provinces still haven't quite peaked. So we may certainly see a longer tail off in this third wave and not quite a smooth downward trend as we saw in the previous waves. That remains to be seen. I quickly want to just show a couple different ways of visualizing the data. So the same data, but looking at it in different ways. And one of the useful ways to look at the trend in cases is to do a phase space plot, or what's referred to as a phase space plot, by looking at by eliminating essentially the time variable or time series. Instead of plotting it over time, we're plotting the number of daily confirmed cases as a 7-day average by the number of total confirmed cases on the x-axis. And what it does is, for one, as mentioned, is you're not looking at a time series, but you are looking at the spread in cases. But what's useful in this curve is that you can pick up when there's certainly a change in either the detection method or there's a change due to different restrictions or lockdown interventions, and certainly can pick up a peak in cases when you notice a change in the trend. So again, this is something that was used earlier on. So the axis may not necessarily be useful for the current period, but if we look earlier on, you'll see a rise in confirmed cases, but then the sudden change soon after our hard lockdown level 5 early in March last year, and that was due to a change in detection method or decline in testing. That then increased again for a while, and then we saw that we surpassed the peak of the first wave. So you'll notice a big change in this plot as well. Similarly, in the second wave and in the third wave. Of course, as mentioned, the scale can be adjusted to look at the different periods more effectively. But essentially, this phase space plot is useful to pick up when there's either a change in detection method or when there's a peak in cases that has been reached. And one can also look at it in relation to when the different interventions were put in place. So maybe just a different way of visualizing the data. The next indicator, which is quite useful and of course crucially important, is hospitalizations. Essentially, all of our measures and interventions are to reduce the burden on hospitals, to not overwhelm the system, and to give people the best access to healthcare facilities so that we can ultimately maximize survival and give people the best access when needed. Unfortunately, a large number of proportion of people do require hospitalization, and this is essentially what's all of our interventions are to try and ensure that our healthcare system is not burdened. One can kind of ask, then why don't we just track this and forget about the rest? The problem is the hospital admissions are a lagging indicator, so too are deaths. Hospital admissions do lag cases and test positivity by about 1 to 3 weeks. And so importantly, we do need to track infections and the test positivity rate to get an understanding of what to expect in the coming weeks in the healthcare system. Of course, in its own right, tracking the trends in the data is useful, as previously mentioned. The good news is that following the decline in infections that we saw nationally, we're starting to see a decline in the number of new hospital admissions over the last week, primarily again due to Gauteng decreasing. But still the number of hospital admissions remains high, and the number of people currently in hospital remains high. This data is based on very useful, the NICD's DATCOV hospital surveillance system, which tracks public and private hospitals, and it's certainly a very useful tool, and the dashboard is publicly available. The limitations in hospital data, there may be a few. One is that I think maybe more so earlier on is not all hospitals may be reporting to the system. I think it certainly has improved now, and I think almost, or if not all hospitals are currently reporting. Unfortunately, there may be a delay in the reporting, and some may not be done timelessly, so that's something to take into account. Not all people or people suffering from COVID-19 may actually access hospitals, either due to different factors, either due to cost or difficulty in actually just accessing hospital networks. So that's something that needs to be borne in mind when looking at this indicator. And then lastly, of course, people may not be able to get access to hospitals due to capacity constraints. And so that's something that is a factor that needs to be taken into account when looking at this indicator as well. Then the number of deaths, unfortunately, is something we do need to track, and it gives really an indication of the burden of and the impact of the pandemic. It is a lagging indicator, lagging cases and test positivity by between 2 to 5 weeks. So that needs to be taken into account. The number of deaths nationally is still increasing, an average of almost 400 per day, unfortunately. So this third wave certainly has been quite devastating for a number of families and people. The limitations when we look at the number of deaths is certainly the number of reported deaths is not a complete picture. We don't necessarily pick up all COVID-19 related deaths, either due to people not testing or not accessing hospitals, dying outside of hospital settings. So another useful indicator to track is the number of excess deaths as reported weekly by the South African Medical Research Council. Of course, the limitation with excess deaths is that it doesn't necessarily tell us 100% what is COVID-19 and what isn't. The breakdown is natural and unnatural deaths. So not all of the excess deaths is COVID specific, but given the geographical spread and the timing or the spread in the excess deaths, certainly a large proportion of excess deaths is related to COVID-19. And maybe as a guideline, the number of actual COVID-19 related deaths is probably 2 to 3 times higher than what is reported. Again, just looking at the deaths indicator, but eliminating the time series, but looking at a phase space plot, as I showed for cases earlier, we can again pick up some useful trends. We know that the reporting may not be as smooth as the number of cases, just due to reporting either delays or just the process. So this curve is not quite as smooth, but you can still pick up sort of when we've reached peaks in terms of the number of reported deaths, etc., in terms of this phase space plot. Maybe something I didn't mention, but what's also useful if we look at phase space plots is you can do country comparisons. I've not shown it here, but you can overlay what the different indicators per country, not in terms of time, but in terms of this type of layout, which can be quite useful in comparing different countries. Something else which is always quite useful to look at is the rate of change in the different indicators, the rate of change in confirmed cases or deaths. You can look at that in terms of a percentage change, which is easy to understand. What's also become really important to track is the reproductive rate, or R number. We're looking at when looking at the change in cases. But another way of looking at the change is in terms of doubling time and how long it takes for these indicators to double. Essentially, we're dealing with exponential growth. So these graphs are a bit old, but they're quite useful in trying to understand when cases and when deaths, or how long it took for these indicators to double. And we still do track this doubling time nationally and per province, maybe not visually as I've shown by these graphs, but I'll refer to them in a sec. Importantly, also, as mentioned, the virus moves as people move. So we do track mobility patterns. And there's different types of movement that we track, be it into homes or into workplaces, into parks, public transports, shopping, etc. And one can really get an understanding of the behavior of people and the movement of people and how it impacts what we then see. It essentially is a precursor to what we see in the spread of infections. Once the infection rates are high, then movement still does, of course, affect the spread, but not necessarily gives an indication as what it does as a precursor, rather. What I'm essentially trying to say is that by tracking movement patterns, we can start to see where we may see an increase in infections 2 weeks after. Remember that the infections that we do report is a reflection of events from 2 weeks ago. This graph here just shows the last few months and the different alert levels. Alert level 2 at the beginning of June, level 3 in mid-June, had little effect on people's movement and behavior. Level 4 certainly with the restriction in gatherings as well, it resulted in a large decline in mobility patterns, and we saw its effect on the epidemiological trajectory. Less so did level 2 and level 3 this time around in our third wave. If we look at the previous waves, I won't go into too much detail, but we know in the first wave, we had a very hard level 5 lockdown, and you can see that the mobility certainly dropped given this big space between the different lines. The red line is movement into residences, when movement started increasing as well. And that also, to some extent, not necessarily a complete indication on its own, but gives some idea of what to expect in terms of a rise in infections due to an increasing movement. In the second wave, what was quite interesting was when we moved from a level 1 into level 3 restrictions at the end of this, a significant influence in the movement and behavioral patterns of people, and how that certainly impacted the epidemiological trajectory in Gauteng and the other inland provinces 2 weeks after moving to level 3. And I think that impact was quite noticeable. So that level 3 certainly had a huge influence in the second wave that we experienced. Less so in the third wave. I think level 4 did have an impact this time around. I won't spend too much time on mobility, but just to mention that I do see that I've time is running. So just a national picture, of course, what's important to understand is that the infection has spread, and the timing and the variation differs in the different provinces. And I think that's important to understand and to look at that. We know that the different waves started in different regions of the country. The first wave started rising in Western Cape, probably due to seeded infections due to international travel in March last year. We then saw that spread in the Eastern Cape and then inland into Gauteng and then KwaZulu-Natal. And other provinces in the first wave. This resurgence started in the Eastern Cape, primarily due to the beta variant that arose and was first detected in the Nelson Mandela Bay region. It then spread into the neighboring coastal provinces, which had a very severe second wave. Thereafter spread into the inland provinces, which were somewhat spared, I believe, due to the level 3 restrictions and the change in people's behavior and adherence and compliance at the end of December. The third wave started probably in inland provinces, Free State, maybe Northern Cape, possibly in the Sedibeng district of Gauteng, but sort of after the Easter period, we saw a rise in the inland provinces, which seem to have all peaked now, but we're still seeing a rise in the 3 big coastal provinces, which haven't actually quite peaked just yet. I think it's quite important to understand. If hopefully we can also take some lessons into account in terms of any possible future resurgence when we start seeing a resurgence in certain regions. We're still seeing a spike in infections in Western Cape over the last few days, and a rise in KwaZulu-Natal and in Eastern Cape, and Free State and Northern Cape haven't quite declined after reaching their peak. They seem to be plateaued at a very high case loading, but Gauteng and its neighboring provinces are on a downward trend promisingly. One can also look at the number of confirmed cases. The previous graph, you look at the case incidence rate, the 7-day rolling average per 100,000 people in each provincial growth. So a useful way to look at this cases is to plot the number of cases on a log scale. So this is a semi-log graph, and what it does, what the use of it is to show the rate of change in infections by looking at the gradient of these curves. And we know that when we exponential growth, and when you plot that on a logarithmic scale, it collapses onto a straight line. So when you see straight lines on a log scale, you know that you're in an exponential growth phase. So this type of plot is useful for understanding the rate of increase orders by looking at the slopes or gradients of these curves. I mentioned about the doubling time when looking at the national figures. We can also look at the doubling rates per province. These graphs are a bit outdated. I think they're from a year ago. We still do track the doubling time. But yes, I think importantly, we can look at the rate of change in terms of how long it takes for cases, in this case, to double in terms of the doubling time, which can be quite a useful and maybe easy to understand indicator. Another way of looking at the rate of change is just looking at the percentage change week on week. Of course, above 10 is a concern, and above 20 really is very high. Essentially, the info that this gives is similar to what the reproductive number gives, is when you're above 0, cases are increasing, and when you look at the reproductive rate above 1, cases are rising exponentially. So it gives kind of a similar type of information in a different way. So I've just sort of, you look at the case incidence rate, which is high across all provinces currently, although some are showing a decrease of late. Particularly Gauteng and the neighboring provinces are showing a decline. There's still an increase in the other provinces, which is shown by the percentage change. I could easily also add a column to show the same info as percentage change by showing the doubling time. And also, again, I could show the reproductive rate, or R naught number, instead of this column, to show the same type of information. I won't spend too much time, but I just wanted to quickly show just other ways in which to visualize the different resurgences per province. And I've just overlaid the different waves for a couple of provinces. I know the big limitation is that the testing rate and the volume of testing per wave has changed. So don't read too much into the graph, but I think visually it's quite impactful when looking at curves like this. It can send quite an interesting message. I think also if you want to, in terms of public understanding and sort of the impact that it has in that sense. So of course, cases are limited by testing. So the testing has varied in the different waves. But what's interesting is if you look at the trend in the waves, how Gauteng's trajectory is quite symmetrical and quite smooth, reaching a peak and then declining. The third wave was quite severe. The number of confirmed cases more than twice as high as the previous two waves. And one can look at that in the different provinces as well. Note the difference in the spread in Western Cape, how it sort of plateaus at a high level for a longer period relative to Gauteng's curve, which is quite interesting. And this curve just shows the situation in KwaZulu-Natal as well. This dip, of course, as we all know, is due to the decline in testing over the week of unrest and rioting. This slide just shows all of the different provinces and how the resurgences track per province, but I won't spend too much time on that. Of course, if this slide just looks at the current resurgence in the darker shaded line relative to what we were seeing at the same time a year ago in the lighter shaded line. I think the take-home message from this is that the timing certainly does vary in the different provinces. For example, last year, Western Cape and Eastern Cape rose first, and this year they are seeing an increase later than the inland provinces. So making it very difficult to plan, but also trying to just get a picture in a different sense of where we're at relative to a year ago. Importantly, as mentioned, cases are limited by testing, so the test positivity rate per province is quite a useful indicator as well. I won't spend too much time on it, but just suffice to say that it does confirm the trend that we're seeing in infections per province as well. We can, of course, look at different districts that are at risk. This is something that the South African COVID modeling consortium, very useful and important dashboard that gives quite a lot of information, amongst other things, which districts are at high risk. Of course, at the moment, all are generally at high risk because of the high infection rates that we see. I spoke about mobility patterns at a national level. I think it's important to also track what's happening at a provincial level, and we do that as well. So kind of giving the same type of message that the virus moves as people move. And when we see an increase in mobility and movement, we tend to also see that as a precursor to an increase in infections in those regions. Of course, we also track what's happened, interventions they're doing, how it works, and lately sort of their vaccination rollout as well, and the impact it's having on their different indicators and whether it's breaking the link between cases and hospitalizations and deaths. We do all of that as well, but maybe just a couple of slides just to give an indication. I think the slide just was looking at countries that were impacted by a resurgence in the Delta variant. And certainly the Delta variant spread to many countries. It's highly transmissible. Fortunately, we are seeing a decline nationally. We also look, of course, at our neighbors and what's the situation there. We know that Namibia saw a very high rate of infections recently, that fortunately they are starting to see a decline. Botswana is starting to see a rapid increase now as well. Maybe of note is something that's happened in Eswatini. They had some to see a surge. So is it a reflection of those rioting actions from a few weeks ago? I can't say what's in KwaZulu-Natal and Gauteng recently as well. So yeah, I think I'm going to stop there. I've rushed through a bit in the interest of time. But yeah, thank you for listening, and hopefully we can take a few questions before we close the session.
Yeah, Dr. Suliman, thank you so much for a really illuminating presentations. You know, probably most of us this morning follow you on Twitter, and it's really very nice to see it all in a more general context. And also, thank you so much for showing the face-based plot that I love. Thank you very much. That was really very nice, and yours looks much better than mine. So thank you very much for that. I convinced Dr. Richard Lessels from the CRISP unit of UKZN to join us, and I coerced him to the panel. And maybe while Ilya and Kimara browse through the Q&A, I can ask Dr. Lessels maybe to give us a first comment from a clinician on the ground. Yeah, Richard, would you mind?
Sure, Francesco. I mean, thanks, Ridhwaan. It's a really excellent talk, and as Francesco says, we all follow you on Twitter and look at the daily updates and the weekly updates, and it's nice to see it all kind of presented here. And I think maybe I can start with just a couple of questions. I mean, I've been kind of looking at the Q&A and trying to kind of synthesize some of the questions.
Okay, thank you very much. So we give you this task, Richard.
Okay.
Thank you very much.
So I start with a couple, and then so Ridhwaan, there's a few questions about the kind of granularity of the data and whether there's kind of better spatial data. I think you kind of highlighted nicely how how looking at the national numbers sometimes hides quite a bit of difference between individual provinces. But even kind of further than that, sometimes looking at a province hides kind of detail at a district level or lower. How good is that data, and do you think it would be helpful to have more granular data, or once you get to that level, does it become more difficult to interpret? The numbers are obviously lower, there's maybe more uncertainty. So I start with that, and then just a kind of addendum to that. Somebody asked this question about the kind of diagnostic fraction that you said, kind of, we think that the diagnosed cases are a significant underestimate of the true infections, and maybe it's 5 to 10 times the number of cases. And I agree with that, but I think people were just asking kind of, how do we know that? What allows us to say that? So those are two initial questions. Thank you.
Thanks so much. Maybe I'll try and respond to those questions while I can. Yes, I think in terms of the granularity, it's quite important. We know that I think the more data that we have, the better it is, not only to help understand, but also to inform people's behavior. And if we have data down to district level in terms of all of these different indicators. I think from my understanding, the difficulty is that the data does, the uncertainty increases because the level of accuracy, the more granular we go, the level of accuracy decreases. I mean, just as an example, when we report the data, I think from my understanding, it's down to people reporting their location and their region accurately, which then that case, for example, can be allocated to a specific district. Some of that may be missing, so we may not have all of the data down to that level. So I think the uncertainty certainly increases the more granular we go. But from our side, we certainly do track data down to district level, and I think it is quite important. I know different provinces and different groups do track it quite down to quite a significant level as well. I know the Gauteng group has a very useful dashboard which looks at specific hotspot regions as well, which is quite important. But I think maybe suffice to say that from our side, we have it down to district level, which is useful in its own sense. Of course, as I've been trying to hint at, the more data that we have, the better for those of us that enjoy data. I think we can certainly learn a lot from it. The question in terms of the underreporting of cases, where does the 5 to 10 times estimate come from? I think, so I've kind of rely on experts for that, but essentially there are probably 3 different ways one can estimate the true number of infections. One can use the test positivity rate somewhat as an indication. When the test positivity rate is surging, you can kind of not exactly extrapolate, but in some way use that to give an indication of what the true number of cases could be if we were testing more. Secondly, one can use seroprevalence studies. There are a few that have been done, although the samples are limited, but one can get an understanding of how many people have been infected by looking at the measuring antibodies in different groups, and then extrapolating that somewhat to understand how widespread infections were. So seroprevalence studies really are very useful as well. One can also look at another indicator and look at the number of deaths that we're reporting, compare that with excess deaths that we are seeing and that the Medical Research Council reports on a weekly basis. And by comparing those indicators, one can also kind of get an understanding of what sense of underreporting there is in deaths, which you can then work backwards by looking at the general infection fatality rate or expected infection fatality rate to what number of cases we likely can be seeing. So there's probably different ways in terms of trying to get the true number of infections. And I think those three different ways that I've mentioned give a good sense of the true reality.
Thank you. Thank you very much. Richard, do you have more questions for Ridhwaan, or can I ask Kimara to guide us maybe to a few more questions from the participants, because I'm seeing that we are already in the extended time.
I can ask two more if you want, Francesco.
Okay, please, that would be great. And then we slowly wrap up. Thank you very much.
I mean,
I think
I know the answer to this one, but it's nice to just hear. Quite a few people are asking, do we now have good vaccination stats? Because obviously it's very often very depressing to look at these graphs, and especially when we're going through another wave, but it's quite uplifting at the moment to look at the vaccination stats and the progress there. And so how good is that data? And is that something that you're following? And then just last question from me, and you don't have to answer this if you don't want to, but we have other infectious disease epidemics that we're tackling in South Africa, such as HIV and TB. We don't do anything like this in terms of following data so closely in real time to try and help us with the public health response. Do you think we should be?
Thanks, Richard.
That's the question.
Thanks, Richard. So yeah, in terms of the vaccinations, I think we certainly have a lot of data and certainly the rollout is speeding up quite significantly, as we are all aware, over the last few weeks. It's not something I track so closely in my personally, but certainly in terms of the data observatory within the CSIR, we have a lot of data from registrations to the rollout of the different types, the J&J doses, the first and second dose Pfizer doses, as the Department of Health has also been reflecting in terms of their publicly available dashboard. I think something that we don't have at this stage is looking at the impact that it has on the different indicators. So what could be quite useful, I think, going forward is looking at the vaccination status and comparing whether we're breaking that link between cases and hospitalizations and deaths, as we're starting to see some data emerging from the UK, which shows that weakening of that link. I think that could be something quite useful as our vaccination rollout picks up and continues to pick up going forward. There's a lot of data in general in terms of that, so I think there could be some, hopefully some promising news that comes out as the rollout does pick up. In terms of other diseases, yes, I think the answer is probably yes. I think COVID is so data intensive, and there's so much data that we're getting on a daily basis from this that is naturally sort of inclined.
It seems we have a little issue with the connection to Dr. Suliman. Richard, is there a final comment that you would like to make?
No, I thought it was great. It was a great
work with data to make use of doing things from the data observatories, look at other diseases, but I think we certainly
Dr. Suliman, I think you might be back. We lost you for 10-15 seconds.
Yeah, so sorry about that. My network just dropped. I think I'm back now.
Yeah, no, now we can hear you clearly again. Thank you. Maybe if you would like to repeat the answer to the last question, because it arrived a little bit in chunks. Yeah.
Yeah, sorry, I'm not sure how much.
Okay, now we can see you. Okay, maybe since we seem to have a little bit of an unstable connection at the moment, and since we are already in extended time, let me wrap up today's data at breakfast by thanking very much Dr. Suliman. Thank you so much for an excellent presentation. And you saw from the number of participants and the number of questions that there was really great interest, and which means that we might have to invite you again in a few months to have an update. I would also like to thank very much Dr. Richard Lessels that I sort of coerced on the spot. Thank you very much, Richard, for your input and for very nicely summarizing the many questions of the participants. That was a really very useful exercise. Last but not least, I would like to thank all the participants for waking up so early this morning and for being very faithful supporters of our data breakfast. And thank you to Kimara and Ilya for working always behind the scenes to make this all happen. So thank you very much again to everyone. Have a good day and hopefully enjoy a very nice weekend ahead. And please stay safe because the COVID is still out there. Yeah. So, and we will hopefully see you very soon again at our data breakfast. Thank you very much, Dr. Suliman. Have a great day as well. Thank you.